We're good to go.
Hi, good evening. This is Dr. Azeem, emergency physician consultant in Yashoda Hospital, Malakpet. Welcome to our Friday webinar. Today, our topic of discussion is snake bite and its management. Uh, Speaker is Dr. Yasaswini, consultant emergency physician in Yashoda Hospital, Somajiguda. Welcome, madam. Over to you, madam.
Hello. Thanks for the opportunity to present this presentation today. The topic is snake bite and its management. So snake bite is an acute, life-threatening, time-limiting medical emergency. It is a preventable public hazard. There are more than 2,000 species in the world and about 300 species are found in India, out of which only 52 are venomous. So mainly they belong to three families, Elapidae, Viperidae, and Hydrophinae. So the Indian cobra and Indian kite belong to the elapids, and Russell's viper and the sask-tailed viper belong to the Viperidae family. So based on the time kites are active during the night hours. So after often biting a person sleeping on floor bed. Viper and cobra bites usually occur during the day or early darkness. So many times victims are not they're misdiagnosed as abdominal colic and vomiting due to indigestion, and many times there is a delay in giving ASV therapy, and also they are subjected to many investigations. So delay in administration of ASV therapy results in severe envenoming and high fatality rate. So morbidity and mortality depends on the age and size of the victim, and the size of the snake and the time of the bite does not contribute to the outcome. The first aid measures are reassure the patient, as in 70% of the patient, the bites are non-venomous, and the as shown in the figure, the limb has to be immobilized with either with a wood or a tree branch, and then patient should be nilled by mouth, and the patient has to be supported to taken to a nearby healthcare hospital, PHC or a hospital where ASV can be given. And patient should not drive himself to the hospital. He should be supported by other person. Motor in rural areas like India, even going by motor vehicle is also okay, but the patient should be supported on the back by other person. And you have to remove any watches, rings, shoes, jewelry, tight clothing from the bitten area, as they can act as tourniquet. And the blister should not be disturbed, and patient should be accompanied by a person. And what we should not be doing, we should not attempt to kill or catch the snake, as this may be dangerous. And traditional remedies like black stones, sacrification, alternative therapy, and herbal therapy have no role, and they do more harm than good. Do not wash the wound or interfere with the bite site. Do not apply or inject anti-snake venom locally. Do not tie tourniquets at it, as it may cause gangrenous limbs. If we expect to reach the hospital in more than 30 minutes and less than 3 hours, crepe bandage can be applied along with the splint, and there should be one finger depth. One finger can be inserted into the crepe bandage. It should not be very tight. It should be done when an experienced person is there. If experienced person is not there, better to avoid it. Mainly, there are four clinical presentation syndromes in the snake bite, as shown in the figure. Progressive painful swelling, neuroparalytic, vascular toxic, and myotoxic are the four presentations. Progressive painful swelling most commonly seen in viper bite, where we see local necrosis, ecchymosis, blistering, painful swelling, and compartment syndrome. In cobra bite, it can be remembered as 5 Ds and 2 Ps: diplopia, dysarthria, dysphonia, dyspnea, dysphagia, and 2 Ps are ptosis and paralysis. And Russell's viper or soft-scaled viper is a vascular toxic. Bleeding and coagulopathy, shock, acute kidney injury are the major manifestations. In myotoxic, that is usually by sea snakes, muzzle aches, muzzle swelling, and compartment syndrome, and involuntary muscle contractions of the muscles are the main manifestations. We also see asymptomatic presentations, that is non-venom related symptoms. These are primarily related to the anxiety, palpitation, sweating, tremulousness, tachycardia, elevated blood pressure, cold extremities, and paresthesias. These may actually confuse us with the diagnosis. Some patients may develop vasovagal shock after the bite or suspected bite. Dry bite. Even in case of dry bite, symptoms due to anxiety and sympathetic overactivity may be present. So neuroparalytic, that is a progressive weakness, elapid envenomation. That symptoms typically start within 30 minutes to 6 hours in case of cobra bite. In crate bite, delayed presentations may be seen like 6 to 12 hours. In some cases, it is also seen after 36 hours in case of crate bite. As earlier said, the symptoms can be remembered as 5 T's and 2 P's. It's the chronological order of appearance of symptoms is from top to bottom, from the furrowing of forehead, ptosis, followed by diplopia, and then dysarthria, dysphonia, dyspnea, and dysphagia. So we can differentiate this from Guillain-Barré syndrome. Guillain-Barré syndrome, we see ascending paralysis, and in this crate bite, neuroparalytic like cobra and crate bite, we see a descending paralysis. So we have to see for impending respiratory failure signs, absent deep tendon reflexes and head lag. It's also called broken neck sign, where we lift the patient and the head falls back. And to identify the impending respiratory failure, bedside lung tests in adults are single breath count. So number of digits counted in one exhalation. Normal is greater than 30. Breath holding time, breath held in inspiration, normal is greater than 45 seconds. Ability to complete one sentence in one breath. In vascular toxic, hematotoxic or bleeding, hematotoxic or bleeding patients, they can have local manifestations as well as systemic manifestations. Local manifestations are swelling, bleeding, blistering, necrosis, pain at the bite site, tendon enlargement of the local draining lymph nodes. Systemic manifestations usually are due to the bleeding, due to action of hemorrhages, gingival bleeding, epistaxis, ecchymotic patches, vomiting, hematemesis, hemoptysis, bleeding from rectum, subconjunctival hemorrhages, continuous bleeding from the bite site, from the pre-existing conditions like hemorrhoids. These are all seen. And local and these are the two figures showing local and systemic vascular toxic manifestations. Gum bleeding on the left image and bleeding from the bite site in the right image. And abdominal tenderness may suggest gastrointestinal or retroperitoneal bleeding, and lateralizing neurological symptoms will suggest the indication of intracranial bleeding. Consumption coagulability detectable by 20 WBC, 20 whole blood clotting test. It develops as early as 30 minutes from the time of bite, but may be delayed also. So locked-in syndrome is a presentation where patient will have quadriplegia and patient will have only vertical eye movement. In complete locked-in syndrome, patient cannot communicate in any form. So central locked-in syndrome is seen due to lesions in ventral pons. So crate bite and cobra bite, these are the peripheral causes of locked-in syndrome. So knowing the peripheral cause of locked-in syndrome is crucial, as they might lead us to wrong diagnosis of the brain death. And locked-in syndrome is completely treatable, and complete recovery can be possible with the timely intervention. Life-threatening complications are acute kidney injury, hypotension due to hypovolemia or direct vasodilation or direct cardiotoxicity, parotid swelling, conjunctival edema, subconjunctival hemorrhage, renal failure, acute respiratory distress syndrome, and refractory shock. Long-term sequelae include pituitary insufficiency with Russell's-Viper, Sheehan syndrome, or amenorrhea in females. So, systemic capillary leak syndrome, it's a rare disorder characterized by episodes of severe hypotension, hypoalbuminemia, hemoconcentration without albuminuria due to profound derangement of the vascular endothelium, resulting in leakage of plasma and proteins into interstitial compartments. Manifestations are like parotid swelling, conjunctival chemosis, myalgia, thirst, and systemic hypotension. Though she's a 17-year-old with viper bite at admission. Same patient with periorbital swelling and conjunctival chemosis. And that is the other image is the parotid swelling developed in adult patient. So painful progressive swelling is one manifestation, one clinical presentation. It is indicative of local venom toxicity. It is prominent in Russell's viper, Haskell viper, and cobra bite. So local necrosis is seen with rancid smell, ecchymosis due to venom action, destroying the blood vessel wall, and significant painful swelling potential involving the whole limb and extending to the trunk. Compartment syndrome will present invariably, and regional tender and enlarged lymphadenopathy is also seen. So these are the pictures of the envenomed foot, and there's a ulcer and in the right foot, in the right image. That has happened. Compartment syndrome has formed due to the tight ligature. Myotoxic, it is seen in sea snake bite. Patient will present with muscle aches, muscle swelling, involuntary contractions of muscles. We can see the passage of dark brown urine. So compartment syndrome, cardiac arrhythmias due to hyperkalemia, acute kidney injury due to myoglobinuria, and certain neuropathic signs are also seen. So Akal snake bite, where the history of the snake bite is not there, it's usually seen in crates, usually present in the early morning with paralysis with no local signs and with no bite marks. So the victims get up early in the morning with the complaint of severe abdominal pain with vomitings, and that will be followed by typical neuroparalytic symptoms. So even in children, if there is unexplained respiratory distress in the presence of ptosis, we should suspect of a crate bite. So assessment, when the patients arrive critical, then we have to assess the circulation, airway and breathing, and deal with any of the life-threatening symptoms on presentation. So vascular toxic patients presenting with bleeding from multiple orifices, they need immediate crystalloids to be given, and then followed by ICU care, pressure support, dialysis, and infusion of blood and blood products. Neuroparalytic patients presenting with respiratory paralysis, tachypnea or bradypnea, or paroxysmal respiration, abdomen and mentation and peripheral skeletal paralysis need urgent ventilator management. Then we have to establish 2 large bore IV access and start normal saline. And before removal of the tourniquet or ligatures, we have to test for distal pulses. If the pulse is absent, ensure a doctor is present before removal of ligatures. In case of clinically confirmed venomous bite, remove tourniquet only after starting of the loading dose of ASV. As the removal of the sudden ligature, removing suddenly the ligature, the poison may rush. So only after starting the loading, only after starting of the loading dose of ASV, the ligature has to be removed. In case multiple ligatures are there, all the distal ligatures can be removed. Proximal one has to be removed only after ASV has been started. So we have to carry out a simple medical assessment, including history, physical examination, every 1 to 2 hourly. Glasgow Coma scale, it cannot be used to assess the level of consciousness of patients paralyzed by neurotoxic venom. So we have to check for pulse rate, respiratory rate, blood pressure, and 20 minutes WBCT every hour for first 3 hours, and then every 6 hours for remaining 24 hours. So we have to check for distal pulses. The presence of pulses does not rule out compartment syndrome, pain on passive movement, pallor, pulseless limb, hyposthesia over the sensory nerve passing through the compartment, or suggestive of compartment syndrome. So when the patients, they are not critical on arrival, and in the patients who are critical patients after stabilization, the patient assessment is, we have to determine the time that has been elapsed since the snake bite and what he was doing in the time of bite, whether he was sleeping on the floor or in the bed on the previous night, if any traditional medications have been used, any brief medical history like last TT, any medications he takes, any other diseases he has like diabetic, hypertensive, or any history of allergies. In case of pregnant women, we have to monitor uterine contractions and fetal heart rate. Lactating women who have been bitten by snakes should be encouraged to continue breastfeeding. So type of how can we identify the snake? We should not we should discourage even bringing the kill snake into the emergency department. If it is brought, then we have to examine it very carefully, as crotalids can poison even when they are dead. And we can use the specimens that are stored in the glass jars for the identification, or we can give them the photographs. Here is a picture of patient identifying the snake on the photograph. And if anyone takes the photograph in their smartphone, that also is useful in identifying the snake. So based on the local bite site on the bitten limb, also we can differentiate the snake. Local swelling, bleeding, blistering, necrosis, it suggests a cobra bite. Minimal local changes and pain in abdomen suggests that it's a crate bite. Local bleeding suggests a Russell's viper bite. So it's a 20 WBCT where 2 to 3 ml of blood is taken in syringe and then placed in the glass tube, and it is left undisturbed for about 20 minutes. After 20 minutes, it is checked if it is clotted or if not clotted. So the first round sample of the patient should be typed and cross-matched, as the effects of both venom and ASV can interfere with later cross-matching. So at primary health center, the other lab test will be peak flow meter presenting with neuroparalytic syndrome, and urine examination for albumin and blood by dipstick. In addition to the above, the other investigations will be prothrombin time, platelet time, clot retraction time, liver function tests, renal function tests, amylase, blood sugars, ECG, ultrasound, and 2D echo. In tertiary care center, ABG and pulmonary function tests are the other that can be done. In vasculotoxic envenomation, for assessing the coagulability, BTCT, PTAPTT, platelets, fibrinogen, FTP, and D-dimer, SA are done. Hemolysis, urine for myoglobin, and urine hemoglobin are the investigations. For renal failure, urine microscopy for RBC, CAS, RFT, urinary proteins, and urinary protein and creatinine ratio. To assess for the hepatic injury, LFTs have to be done. For cardiotoxicity, CPKMB, 2D echo, and BNP. For myotoxic, CPK, SGOT, urine myoglobin, and compartment pressures have to be assessed. For infection, serum procalcitonin, cultures, and sensitivity. Arterial blood gas and urine examination should be repeated at frequent intervals during the acute phase to assess progressive systemic toxicity. So anti-snake venom therapy. So if ASV is indicated, that is symptoms and signs of envenomation with or without evidence of laboratory test, administer full dose without any delay. Do not wait for any test report. So in a patient with history of bite, whether it is known or unknown, if there is spontaneous abnormal bleeding beyond 20 minutes from the time of the bite, start ASV. We need not wait for the 20 WBCT report. And there are no absolute contraindications to ASV. Purely local swelling, even if accompanied by bite mark from an apparently venomous snake, is not a ground for administering ASV. However, if the swelling is rapidly developing, it indicates bite with envenoming, so it requires ASV. So how it should be reconstituted? So along with the it comes as a powder, and that has to be reconstituted along with the 10 ml reconstituting fluid or normal saline. So that has to be, it makes up 10 vials into 10 ml, it makes up to 100 ml. Usually it is given in 100 ml of this ASV dose is mixed with 400 ml of normal saline. It is given over 30 minutes to 1 hour. So for neuroparalytic snake bite, ASV 10 vials, we have to give over 30 minutes to 1 hour. And if there is no improvement after 1 hour, we have to give the second dose of 10 vials. For vasculotoxic snake bite, there are two therapies: low dose infusion therapy and high dose intermittent bolus therapy. So 10 vials for Russell's viper, 6 vials for saw-scaled viper as infusion over 30 minutes. Then it is followed by 2 vials every 6 hours as infusion in 100 ml of NS till clotting time normalizes, or for 3 days, whichever is earlier. In high dose intermittent bolus therapy, 10 vials we have to give over 30 minutes, followed by 6 vials every 6 hourly till clotting time normalizes. So for sea snake bite, we should not give ASV as it does not contain the antidote for that snake bite. And also confirmed green pit snake bite, even with if signs of inflammation are available, we should not give the ASV. So ASV has to be given only by IV route. So patients have to be monitored every 5 minutes for first 30 minutes and then at 15 minutes for 2 hours. We have to give the prophylactic adrenaline. The dosage is 0.25 mg of 0.1% solution by subcutaneous injection. And before administering, we have the physician we have to be ready with 2 syringes drawn with adrenaline. ASV dose in pregnancy, it is the same as the dose in any other individual. After the ASV is completed, we have to refer to the gynecologist to assess for the fetal health. ASV dose in children is also same as the ASV dose in any other patient. Only that the reconstitution fluid has to be made according to the weight of the child, like 10 to 20 ml per kg. ASV dose in victims requiring life-saving surgery, like patient is having intracranial hemorrhage due to consumption coagulopathy. Then in such cases, up to 30 vials of ASV also can be given and then taken for the, that coagulopathy has to be corrected and taken for the surgery. So repeat dose of ASV, when we should repeat the dose of ASV. So we have to repeat the clotting test every 6 hours and administer ASV every 6 hours until coagulation is restored. In patients who continue to bleed briskly, repeat ASV within 1 to 2 hours. If 30 vials of ASV has been administered, and we have to check whether continued administration is serving any purpose, particularly in the absence of proven systemic bleeding. If large doses have been administered and coagulation abnormalities persist, we have to give FFP or cryoprecipitate, or give fresh whole blood if both FFP and cryoprecipitate are not available. In neuroparalytic envenomation, initial dose is 10 vials. Second dose of 10 vials if no improvement within first hour. So sometimes repeat second dose may also be required even after 2 to 3 hours if relapse of signs of neurotoxicity are noted. So maximum dose is 20 vials of ASV for neurotoxically envenomment patients. In victims who arrive late, like after some days, they might arrive with clinical symptoms like pain in the limb. Then we have to assess if the symptoms are still present and ASV can be given. Like if the consumption 20 WBCT is not clotted, we can give the full dose of ASV. So ASV reactions. There is no indication to give ASV test dose because many times, even if there is no reaction to the test dose, when the actual ASV full dose is administered, reaction can be seen. And early anaphylactic reactions occur within 10 to 180 minutes of the start of the therapy. A minority of these patients may develop severe life-threatening anaphylaxis like hypotension, bronchospasm, and angioedema. Pyrogenic reactions usually develop 1 to 2 hours of the treatment. And any new sign or symptom after the starting of ASV in drip should be suspected as reaction to ASV. Late serum sickness type reactions develop 1 to 12 days. The mean is 7 days after the treatment. So pre-medication with adrenaline. So it is 0.25 mg of 0.1% solution by subcutaneous injection. And except for hypertensives and patients present with blood pressure more than 140/90, or if there is any suspicion of underlying cardiovascular diseases. In all other patients, we have to pre-medicate with adrenaline. So giving steroids, histamine, antihistaminics have no proven benefit. So when ASV, early ASV reactions, the treatment is we have to stop the ASV temporarily. We have to give oxygen, IV normal saline with a new IV set. We have to give adrenaline 0.5 mg IM. We have to give chlorpheniramine maleate. Hydrocortisone can also be given, but it will take some hours to act. Once the patient has recovered, we have to restart ASV slowly for 10 to 15 minutes, keeping the patient under close observation, then resume normal drip rate. For high risk patients, we have to go hydrocortisone 200 mg and chlorpheniramine maleate 22.75 prior to the administration of ASV. Treatment of late reactions like serum sickness type, we have to give chlorpheniramine injection 2 mg in adults 6 hourly for 5 days. In patients who fail to respond within 24 to 48 hours, we have to give a 5-day course of prednisolone. There is a desensitization procedure. It has to be done in severe anaphylaxis reaction to ASV with shock and generalized anasarca after injection of very few ml of ASV, usually less than 5 ml. We have to first change the batch of ASV. We have to pre-medicate with hydrocortisone 100 mg and injection adrenaline 0.5 subcutaneously or IM. Then we have to take dilute 1 ml of ASV in a vial with 10 ml of normal saline. That is solution A. 1 ml of solution A plus 9 ml of saline, that is B. The dilution is 1:10. 1 ml of solution B plus 9 ml of saline, the dilution is 1:100. 1 ml of solution C plus 9 ml saline, it becomes solution D. The dilution is 1:1000. And then we have to take 1 ml of this solution D plus 9 ml saline we have to add. Total becomes 10 ml. That is solution E, which is 1:10,000 dilution. So then we have to inject 0.1 ml of solution E and watch for anaphylaxis for 15 minutes. If there is no reaction, we have to give 1 ml and watch for 15 minutes. And if there is no reaction, inject entire solution E. And after solution E is injected, we have to continue the same process for solution D, C, E, C, B, E, A. So management of neurotoxic envenomation. Anti-snake venom treatment is not alone enough. We have to treat the patient with other measures like giving oxygen, assisted ventilation when the patient develops bulbar or respiratory paralysis, and atropine neostigmine. We have to administer atropine neostigmine. So rapid deterioration of cobra bite neurotoxic syndrome may kill the patient on the way during transfer. Some patients go into deep coma state but recover completely. Hence, diagnosis of brain state should not be considered. And atropine neostigmine should not be given in case of confirmed snake bite. This is a schedule for atropine neostigmine dosage. Atropine 0.6 mg followed by neostigmine to be given IV stat and repeat dose of neostigmine 0.5 mg with atropine every 30 minutes for 5 doses. After 5 doses, we have to give as a tapering dose at 1 hour, 2 hours, 6 hours, and 12 hours. So majority of the patients improve within 5 doses. Observe the patient closely for 1 hour to determine if the neostigmine is effective. After 30 minutes, any improvement should be visible by an improvement in doses. Positive response to AN trial is measured as 50% or more recovery of the doses in 1 hour. We have to stop the AN dosage if patient has completely recovered from the neuroparalysis. Patient shows side effect in the form of fasciculations if there is no improvement after 3 doses. So when the patient improves by atropine neostigmine infusion, it indicates the cobra bite. If there is no improvement after 3 doses of atropine neostigmine, it indicates probable crate bite. And the crate affects the presynaptic fibers where calcium ions act as neurotransmitter. So we can give injection calcium gluconate 10 ml IV every 6 hourly till the neuroparalysis recovers. Management of vasculotoxic snake bite. We have to advise strict bed rest to avoid even minor trauma. We have to screen for hematuria, hemoglobinuria, myoglobinuria by dipstick method. We have to closely monitor urine output and maintain 1 ml per kg per hour of urine output. The patient is bleeding severely irrespective of full dose of ASV or is already seriously anemic, we have to give transfusion of blood of FFP or transfer to the facility where it is available. Prompt recognition of organ dysfunction and immediate intervention may reverse organ impairment and improve the outcome. So, volume replacement and snake bite. We have to establish the IV axis. Initially, we have to give 200 ml of saline in 5 minutes. Check BP, check a response. If there is a positive BP response, then we have to give additional fluid over 30 minutes, 200 ml, or until the jugular venous pressure or central venous pressure has risen to 8 to 10 centimeters above the sternal angle. We have to carefully observe the patient while this is being done. The fluid challenge must be stopped immediately if pulmonary edema develops or patient starts complaining of breathing difficulty. Forced alkaline dialysis. If urine output does not improve or dipstick positive for blood, we can give a trial of FAD within first 24 hours, as it can avoid pigment nephropathy leading to acute tubular necrosis. We have to initially give injection furosemide 40 mg IV stat, then normal saline 500 ml with 20 ml of soda bicarbonate over 20 minutes, followed by ringer lactate solution 500 ml with 20 ml of soda bicarbonate over 20 minutes. Then we have to give 5% dextrose 500 ml with 10 ml of potassium chloride over 90 minutes. And then mannitol 150 ml over 20 minutes. Those are all this will take 2 hours 30 minutes and urine output of 3 ml per minute is expected. If patient responds to the first cycle, we have to continue this for 3 cycles. Forced alkaline dialysis converts oliguria into polyuria and avoid acute tubular necrosis and acute kidney injury needing dialysis in more than 70% of the patient. If there is no response to furosemide, we have to discontinue forced alkaline dialysis and refer patient immediately to a health center for dialysis. Management of hyperkalemia. In hyperkalemia, that is usually greater than 7 millimole per liter, or hyperkalemic ECG changes, that is tall T waves, prolonged PR interval, absent P wave, white QRS complexes. We have to give calcium gluconate 10% over 2 minutes. It can be repeated up to 3 times. 50 ml of 5D with 10 units of soluble insulin IV and soda bicarbonate 40 ml of 8.4% solution by slow IV and salbutamol aerosol by inhaler may be used. Management of severe acidosis. If the patient is hypertensive and profoundly acidotic, that is Cossimol respirations, variable plasma bicarbonate level or very low pH, that is less than 7.1, we can administer sodium bicarbonate. We have to calculate the bicarbonate deficit and we have to administer 2 to 3 ampules in 5D water, or half of the calculated deficit can be replaced in 3 to 4 hours. So what are the indications for dialysis? When the absolute value of blood urea is greater than 130 milligram per deciliter, creatinine greater than 4 milligram per deciliter, or there is an evidence of hypercatabolism in the form of daily rise in blood urea 30 mg per deciliter, serum creatinine greater than 1, serum potassium greater than 1 milligrams per liter, and fall in bicarbonate greater than 2 millimole per liter. So these are all the indications for dialysis. Others are fluid overload leading to pulmonary edema, hyperkalemia, when the patient is unresponsive to conservative management, and when there are uremic complications like encephalopathy and pericarditis. In case of shock and myocardial damage, we have to first correct hypovolemia with colloid crystalloids, controlled by observation of the central venous pressure. Uh, then this should be done carefully while the hypertension is being reversed. That whether the your output is increasing and whether the normal capillary refill is being attained, per- and we have to monitor for the peripheral pulse and level of consciousness without inducing lung palpitations or hepatomegaly. If hepatomegaly or rails develop, and if patient does not respond to fluid resuscitation, inotropic support must be given. We have to give atropine in patients with hypertension associated with bradycardia. For coagulopathy, we have to give FFPs and cryoprecipitate, and we have to avoid intramuscular injections. And PC of 30% must be maintained. Therefore, measure serial PCV every 4 to 6 hours, depending upon the bleeding severity. If it is lower than 30, it needs blood transfusion, PCV transfusion. The aim of FFP transfusion, that is coagulation control, is defined as INR of less than 2 at 6 hourly after ASV administration was commenced. Heparin is ineffective against venom-induced thrombosis and may cause bleeding on its own account. Antifibrinolytic agents are not effective and should not be used in victims of snake bite. Management of severe local envenoming, local necrosis, compartmental syndromes, and even thrombosis of major vessels is more likely in patients who cannot be treated with ASV. So surgical intervention may be needed. We have to give prophylactic antibiotics, broad spectrum antibiotics for cellulitis, usually amoxicillin claviclinic acid and ceftriaxone are preferred. Recovery phase. So response to infusion of ASV is marked by normalization of blood pressure. Within 15 to 30 minutes, bleeding stops, though coagulation disturbances may take up to 6 hours to normalize. In neurotoxic envenoming of the postsynaptic, that is in cobra bites, begin to improve within the first 30 minutes. But patient may require 24 to 48 hours for full recovery. Envenoming with presynaptic toxins, that is crates, they do not respond in this way. Usually takes a considerable time to improve. Recovery of respiratory muscles is reflected by improvement in neck flexors, where flexing the neck against the gravity indicates timing to wean off the ventilation. In shock patients, blood pressure may increase within the first 30 to 60 minutes, and arrhythmia such as bradycardia may resolve. Acute hemolysis and rhabdomyolysis may cease within the first few hours, and the urine returns to its normal color. Patient in deep coma recover fully provided there is no hypoxic brain damage. Autonomic dysfunctions are transient and they don't need any treatment. Other measures are, we have to clean the bitten site with provided iodine solution, but do not apply any dressings. Blisters have to be left alone. We have to give tetanus toxoid injection. For mild pain, usually we have to treat with paracetamol or tramadol. We should not give NSAIDs or aspirin. We have to avoid drugs such as sedatives and paralytic agents, pethidine, morphine, neurotoxic envenomation. We have to maintain good hydration and nutrition. If there is local pain and spreading edema, we can elevate the affected limb. Surgical procedure in snake bite, debridement of necrotic tissue, it is done. We have to wait for 5 to 7 days before commencing debridement in order to specify the line of demarcation between the viable and non-viable tissue. Compartment syndrome, the 5 Ps: pain, pallor, paresthesia, pulselessness, paralysis or weakness of the compartment muscle. When we have to do fasciotomy, when there is clinical evidence of intercompartmental syndrome, intercompartment pressure is greater than 40 mmHg of normal saline. It can be measured by three-way cannula, that 16G needle is attached to one end, PP apparatus is attached to second, and the saline infusion to the third side. This can also be confirmed by vascular Doppler and raising CPK in thousands. Timely fasciotomy decreases the need for repeated dialysis. Hemostatic abnormalities have been corrected before fasciotomy has to be done, as otherwise it may lead to bleeding to death. Early treatment with ASV remains the best way of preventing irreversible muscle damage. Corticosteroids should not be given, as they're not effective in ameliorating the local effects of envenoming and carry the risk of side effects. The limb can be raised in initial stages to see if the swelling is reduced. Persistent moderate swelling of the limb after viper bite can be successfully managed by systemic broad-spectrum antibiotics and repeated magnesium sulfate compresses. The compartment syndrome measurement procedure. So 16 mg 16 gauge needle is inserted 1 centimeter deep into the muscle, and to one end it's a three-way. So one end normal saline is attached, and to other end is attached to the BP apparatus. Any patient with the history of snake bite, we have to admit the patient for 24 hours and discharge only after 24 hours if they don't develop any signs or symptoms. If the ASV has been infused, we have to keep the patient under observation for 48 hours. Follow-up at the time of discharge, they have to be advised to return to the emergency if there are any worsening of symptoms such as bleeding, pain, or swelling at the bite site, any difficulty in breathing, altered sensorium. We have to explain the patient regarding the signs and symptoms of serum sickness, that is fever, joint pain, joint swelling, which may manifest after 5 to 10 days. Rehabilitation. In patients with severe local envenoming, maintain limb in a functional position and start simple exercise while the patient is still in the hospital. Functional effects of local envenoming range from persistent stiffness and induration to severe deformity, tissue loss, especially dermonecrosis, requiring skin grafting and gangrene requiring debridement. This is a broken neck sign. Thank you. Hello?
Thank you, madam. Thank you for your wonderful presentation. I think you have elaborated in a brief manner. There are no queries or questions regarding this topic. And I thank our chairperson, Dr. Srinath sir, and our organizing secretary, Dr. Kiran Varma sir, and Dr. Vinith sir, and our organizing team, Sowjanya madam, Dr. Sowjanya madam, Dr. Raghu sir, and Dr. Malaya Mishra sir. Thank you, ma'am.
Thank you.